Hello, this is Scott, and this lecture in the Transgender Health Lecture series focuses on the transgender pediatric patient. The diagnosis of gender dysphoria in children is complicated. Many children will explore their gender identity, but most will resolve to their sex assigned at birth by adolescence. However, in some children, these feelings intensify during puberty and gender dysphoria worsens, and then you have a transgender patient. Based off these observations, it's recommended that children be able to socially explore different gender roles before puberty, but that you use puberty-suppressing agents only once puberty has onset. Treatment aimed at aligning a child's gender expression with sex assigned at birth has been attempted without success in the past and is no longer considered ethical. Early social transitioning is not currently recommended by WPATH. Early social transition can occur in some families with success. However, gender dysphoria in early childhood often resolves. A change back to the original gender role may be traumatizing. However, there's no research on this phenomenon currently. A 2019 paper found that children who identified strongly enough with a transgender identity to ask to socially transition were almost certain to identify as transgender throughout adolescence, regardless of any attempts at early social transitioning. As of yet, there's not sufficient evidence to support or refute early social transition. However, children should be allowed to explore their gender identity without pressure either way. Per the 2017 Endocrine Society guidelines, children who meet criteria for gender dysphoria or gender incongruence, fulfill criteria for treatment, and are requesting treatment should undergo pubertal suppression. Per the same guidelines, pubertal hormone suppression should not begin until patients exhibit the first physical changes of puberty, starting at Tanner stage 2. This is supported by WPATH also. It's important to know that not all clinics, even those specializing in transgender healthcare, will offer puberty suppression, and that there is no agreed upon time upon which to start pubertal suppression, with many clinics starting anywhere between Tanner stage 2 and Tanner stage 4. There is some evidence that delaying pubertal suppression in male to female patients to later Tanner stages allows for development of extrascrotal tissue, which may be then used in vaginoplasty once the child reaches the age of consent. Leuprolide is a gonadotropin-releasing hormone analog, which suppresses luteinizing hormone and follicle-stimulating hormone through the overstimulation of pituitary receptors. LH and FSH are dependent on pulsatile secretion of gonadotropin-releasing hormone, and overstimulation results in no release of LH or FSH, thereby suppressing pubertal development. This has been used for a while for precocious puberty, and those people with precocious puberty who stop leuprolide wind up undergoing normal pubertal development. There is some risk for adverse effects on bone mineralization with leuprolide, which is theoretically reversible with sex hormones, and there also might be effects on neural development. This was not fully elucidated in the primary literature, but there is no current research on neural development, although I'm not entirely sure what the risk is. Probably because you're affecting the hypothalamic pituitary axis, there's some concerns that there might be effects on neural development. It's found that GnRH analogs increase final height due to delayed estrogen-induced fusion of growth plates. This is important to counsel patients on, as transgender women generally prefer a more stereotypically feminine petite stature, while transgender men generally favor a taller stature. So this increase in height, in general, of course it's patient-dependent, might be adversely affecting transgender women, while be a potential therapy for transgender men. While on pubertal suppression, patients should have their height, weight, blood pressure, and Tanner stage evaluated, along with LH, FSH, estradiol, testosterone, and vitamin D levels. Every 1 to 2 years after starting pubertal suppression, bone density should be taken using DEXA scanning, with bone age on the x-ray of the left hand if clinically indicated. Many patients don't start puberty suppression until later Tanner stages due to delays in seeking treatment, and in general are candidates for hormone therapy before really any effects on bone density might be started. However, it's important to know these for these patients. Adolescents who request sex hormones may be started on hormone therapy if they have a long history of gender dysphoria and approval from a mental health professional specializing in transgender medicine. In general, patients aren't started on hormone therapy until age 16, although the earliest a patient may be started per the WPATH guidelines is generally around 14 per Endocrine Society and WPATH recommendations. However, in general, you must wait until you're 16 in order to have hormone therapy. Puberty development should be monitored every 3 to 6 months, and laboratory testing should be done every 6 to 12 months during sex hormone treatment. Transgender adolescents should be counseled on the effects on fertility. If a patient is arrested in Tanner stage 2 with pubertal suppressing agents and then started on hormone therapy, they will not develop functioning sperm or ovum. There is some current research being done with spermatogonium stem cell and testicular tissue preservation for fertility preservation of prepubertal transgender patients. However, they are not yet clinically available and are still only available in a research setting. Patients should be counseled on the effects on puberty, and timing of gender-affirming hormone therapy should be taken into consideration with respects to future fertility.